Hello, and thank you for inviting me to speak to you today. My name is Dr. Sebastian Lunke, and I'm the head of the Division of Genetics and Genomics at the Victorian Clinical Genetic Services in Melbourne. VCGS is a not-for-profit organization that has been active in the space of genetics for several decades. We are based out of the Royal Children's Hospital in Melbourne and are a wholly owned subsidiary of the Murdoch Children's Research Institute. We've been accredited for genomic testing for over 5 years, but are also very active in areas of research and translation. One of our core strengths is our fully integrated clinical service, which means we have strong multidisciplinary teams with clinical geneticists, genetic counselors, bioinformaticians, and scientists. VCGS operates across a full spectrum of germline genetic disease, but one of our core areas of expertise is in clinical genetics and genomics. This is the area we're going to focus on today, and I'm going to discuss with you the challenges of implementing and maintaining a clinical genomics service. At the core of clinical genomics is obviously the revolution in technology. Sequencing technology has evolved from single gene and very targeted, cumbersome manual sequencing via the first human whole genome to today being able to sequence many human genomes in a single day for a few $1,000s. I often compare this to the transport revolution. It's like going from a horse and cart to switching to a car to now being able to fly a fighter plane. However, technology alone is not enough to create a clinical genomic service. There's a number of key challenges that we face on a day-to-day basis that we need to continuously tackle. We have to improve and validate the technology that we work with, we have to scale the service to demand, and we have to continuously strive to reduce the cost of service delivery. The first challenge is one of the hardest ones in establishing the service. Research technology requires validation before it is fit for use in a clinical setting. The fighter plane is exciting, but what we really want for our patients is a safe way to deliver the testing results that is highly reliable and high quality. When VCGS embarked on that journey in 2015, we were one of the first labs in Australia to try and offer genomic testing in a clinical setting. So we had to undertake our validation without well-established guidelines and reference standards, and even the bioinformatics we were using at the time was very much homebrew and highly customized. So validation represented an enormous challenge in these days. We tested hundreds of samples, we curated several hundred variants to make sure that both our analytical and our clinical validation is up to par. We also had to set up custom quality assurance schemes and participation because most of the commercially available schemes today didn't exist back then. So this was a very expensive exercise. Today, validation is very much routine. It recurs with a high frequency as new chemistry becomes available, new technology becomes available, or existing technology changes, and in particular as bioinformatic tools evolve. So today we have a well-established set of reference samples with multiple in-house data sets as comparators, and we really managed to develop a semi-automated validation framework, which now brings the time of validating a new assay from months down to days. We also started using a mix of commercial and in-house software to get the benefits of both leading-edge technology and ease of use and maintenance. However, there are certainly still some areas that present significant challenges, especially when it comes to extending the limits of technology. A good example is to try and establish calling of new variant types in whole genome data like repeat expansion, structure variants, and copy number variants. Another key challenge is cross-training of scientists and software engineers. Most of the improvements these days come from the bioinformatics area. However, software engineers are often not very well versed in the needs of a clinical laboratory, so finding and training the people that are across both areas is key. So in the future, we really need yet more and better reference sets from a much wider range of variant types. But we also want to strive towards full automation of our validation frameworks with a strong contingent of very well cross-trained software engineers and scientists. Another key challenge that we face in our daily practice is scalability of the service. And we need to scale both to an increasing demand as well as a changing demand while maintaining high quality. The key challenges we see today are driven really by an increase in knowledge and change in the funding landscape, both of which drive the volume of the tests that are ordered, as you can see on the right side here. We really need to be able to scale our service to deliver ever-increasing volumes with a clinically relevant turnaround time. At the same time, genomics is becoming rapidly established as a key diagnostic tool in an urgent care setting. So not only do we need to adjust to a higher volume, but we also need to adjust to a demand for much faster turnaround times than what we would offer in a routine care setting. And as I said, we need to do all of that while maintaining a high quality of care for both our referrers and patients. To meet the challenge of volumes, traditionally we've simply tried to hire and train more staff. And at VCGS over the last few years, the staff contingent has grown rapidly with the increasing demand for our service. However, hiring staff alone is not sufficient, as these people need to be highly skilled. There's not many of them around. And even then, they still take 3 to 6 months to train before they even come to a basic level of being a clinical variant curator. So we also needed to improve our processes, and we were lucky that we could heavily rely on our clinically integrated model, where we can work very close with our clinical team to work through the data that is available on every patient and focus in on the variants that are most important for that patient. That is what is commonly referred to as phenotype-driven analysis, which really allows us to focus in on the variants of highest relevance and therefore save curation time but not spending time on variants that are not relevant to the particular case. Another key aspect of phenotype-driven analysis is the use of indication-specific custom or in silico gene lists. Our gene lists now are all available in an instance of Panel App Australia where they can be freely accessed, and we're using those again to focus in on the variants of highest importance. But we're using it as a soft filter and prioritization tool. If we don't find the answer, we continue to work through the whole data set on this until we either find a suitable answer or we can be confident that the case is negative. So that system has served us very well so far. While we were called out in the early years by the increase in demand, and our turnaround time very much blew out to well over 9 months, we were then able to use our process improvements and our staff training to bring that back down into what is now a pretty stable and clinically acceptable turnaround time of an average of less than 3 months. At the same time, we managed to maintain a high diagnostic yield across all indications with an average of 43% of cases currently in our laboratory receiving a diagnosis. Having said that, a 3 months turnaround time is still too slow in certain settings. And in particular for pediatric patients that end up in intensive care units in the various hospitals across the country, a 3 months turnaround time is unfortunately not clinically relevant. In Australia, 5% of the neonatal intensive care units admissions are due to an underlying genetic condition. So genomic testing has high value in that setting, not least because any day in ICU is very expensive. So if we can help solve and diagnose a case quicker, there's big benefits for the health system in there. However, we need to be able to match our turnaround time to the clinical acuity of the situation. And in an ICU setting, decisions are made on a scale of hours or days and not months or years. So we really needed to aim to get the turnaround time of our test down to a space of days to be able to develop and deliver relevant results in that setting. The key problem is that all processes associated with genomics in our lab were geared towards cost efficiency and not speed. And that meant that in many stages, samples get held up for the purpose of batching to find new samples and to fill up batches to make sure that we make the most cost-efficient use of our equipment. So this could often take up to 60 working days or 12 weeks in routine settings, even if there aren't any delays. And while we were able to improve the processes to a way where we could approach the ideal case of about 3 weeks, which we now call a rapid turnaround time, and these results have been published in Genetics and Medicine in 2018, that was still not enough to get to the target of only a few days to be relevant in the ICU setting. So what we had to do is we had to redesign our systems from scratch and really make sure that we deliver this test as fast as possible without paying heed to the cost implications. In doing that, we have established the Acute Care Genomics project in Australia with support from the Australian Genomics Health Alliance, as well as the Australian government, and really managed to adjust our processes in a way that the turnaround times decreased to a theoretical optimum of now 46 hours. And today we do this as a routine test with a quota turnaround time of 5 days. The only reason why we go up to 5 days is so we can allow for multiple failures in the system and still meet our targets. Consistency of in setting expectations correctly is very important in the setting, so the clinicians can know when to expect their result. We have been very successful in the setting. We have now delivered over 200 test results, all of which have been under 5 days. And as a matter of fact, our average turnaround time for these cases is now just under 3 days. And we've managed to make this program available across all of Australia with now several dozen NICUs and PICUs being part of this exercise. This data has also been extensively published. Not only the summary of the first cohort in acute care, but also the process improvements we have been driving, and in particular the lead of the acute care genomics process, my colleague Professor Zonitza Stark, has been driving in the clinical setting to make sure that the clinical geneticists, genetic counselors, all the systems surrounding this test are also in line with a fast turnaround time. So this was really an effort and whole of system change, which we have been delivering quite successfully for the last few years. So the challenge of scale and speed has been addressed with workforce training and process optimization to improve both output and speed of our assays. But demand for genomic testing is only going to continue to increase. And we're also seeing an increase in case complexity, which is putting pressures on our throughput because we need to spend more time per case. So training of ever more staff is just not a feasible proposition. There are skills shortages in this area and the lead times for training are just way too long. So in reality, in the future, we just need to be more efficient in how we process these cases. And the answer really lies in 3 key areas. We need to continue to improve our processes and our analysis tools just for faster turnaround time. But we also need to continue to expand on the value we get out of our multidisciplinary teams, including the clinicians, the scientists, and the technologists like bioinformaticians and software engineers to really make sure that we've got the best possible systems available to analyze that data. Machine learning will actually play a crucial role in that space. However, it will not solve the problem for us, but rather support our efforts. It will really help us to almost fully automate the easy cases, so we can focus the expensive skill of the experts on the more complex cases and thereby increase the throughput of the whole system. The third challenge is really in trying to reduce the cost of service delivery, and this is crucial if we want to make the service available to as many patients as possible. And one of the key challenges is that sequencing data generation remains expensive. There's a lot of noise out there that says that the cost of data generation continues to drop, and that is true. However, the numbers that are routinely quoted are unfortunately not quite applicable in a clinical setting, because data generation only presents a fraction of the cost, a substantial fraction, but only a fraction of the cost of actually providing a clinical report. So while we can make savings in that area, we also need to look at other areas to generate savings. And the solution to the cost challenge are really stemming from the solutions to challenges 1 and 2, where we have to utilize higher throughput, efficiency, and automation to reduce our labor cost, which are really the main component of the service delivery these days. But we also need to utilize our efforts in rapid validation to be able to pivot quickly to new technologies that are hopefully better and cheaper. And a key example of that is a recent piece of work we've undertaken in collaboration with Twist, where we've changed our exome chemistry to develop a higher quality and more clinically relevant assay. The higher clinical relevance comes from a custom design that we've undertaken with Twist that not only boosts the coverage of the assay in the clinically relevant genes, but also incorporates known intronic pathogenic variants in the design, thereby extending the scope of the exome really to include non-coding, non-pathogenic variants. But we've also managed to have an assay and utilize the strong technology of Twist to achieve an assay that has better coverage, despite utilizing less sequencing real estate and therefore being cheaper. And what I mean by that is quite obvious, I think, in these graphs where we compare at key quality metrics of coverage over 10 and 20x, the percent of bases that are covered at those key thresholds in different data sets with different mean coverage as compared to our previous exome. So where previously we targeted 100x mean coverage in our data to achieve a reliable threshold over 20x, with Twist, we at the same mean coverage we surpass the number of bases, but even at lower coverage of 80 and 50x, the assay does perform certainly better than our previous assay. Even arguably at coverages down to as low as 40x, we see very, very strong performance at that key metric of bases covered over 20x. And the key outcome of that is really that we have more regions in the exome that are reliably covered or less gaps. Where in the previous assay we had a combined total gap size across the whole of the coding region of just under a megabase or 0.8 megabase. With Twist, that at 80x that has dropped to 160 kilobases. And even at half the coverage of the previous assay, we still see substantially better performance of the Twist data. So in end effect, we ended up with a much better assay at substantially lower cost. But in addition to automation and rapid validation and technology changes, we also managed to consolidate our service provision to a much smaller number of technologies. And in particular, we have stopped offering targeted panels because with the current technology and the laboratory benefits of consolidating the workflows, exome sequencing is actually now becoming more cost efficient than using a number of different targeted panels. And we're also undertaking efforts to maximize the utility of data because data generation remains a high cost item. If we can reuse the data in different settings, we can generate more value for our patients. And in particular, we can reuse the data in the areas of prenatal testing. Carrier screening is going to be a big piece in the future, or additional analysis of data for secondary findings. So in the future, we hope that data generation is going to be cost efficient routine, and that we perform analysis repeatedly on the same set of high quality data. Really what we need to achieve is a concept of what I call lean laboratories, where we have a minimum number of processes supporting a maximum number of applications. And that's really how you get cost efficiency in the system. But we also need to continue to improve our integration of data and data flows and work towards fully automated analysis of routine or easy cases. Most importantly, we have to constantly continue to innovate. So while we have now managed to take the new technology and make it applicable in a clinical setting, you could argue that compared to a fighter jet, a passenger plane is rather boring. I don't quite see it that way, in particular because I know what we are working towards is really something like this, which is the future of clinical genomic technology, but while maintaining a safe and reliable system for our patients. With that, I'd like to thank my key collaborators and colleagues in this project, as well as the key funding agencies that have supported this work. And I'd like to thank you for paying attention to my talk, and I will be available for questions after this recording.